Our study investigated what it's like to manage children's asthma in the US, looking specifically at two places, St. Louis, Missouri, and Gainesville, Florida. We conducted this study in 3 parts. We interviewed 41 caregivers about what it's like caring for a child with asthma. We then interviewed 12 asthma care providers in a range of roles, including specialists, school nurses, and emergency care providers. And finally, we visited family homes and talked to 24 children with asthma or their siblings. Most of the caregivers and children we spoke to were African American and were from low-income households. They offered a lot of insight into what it's like managing asthma in conditions of disadvantage. Difficulties with housing meant that mold, dust, and pests were often making children sick, but financial strain meant that moving wasn't easy either. Sometimes caregivers felt trapped in environments that were making their children unwell, and families often had many other medical or social issues that overwhelmed asthma care. When you have a mom with cancer, another child with autism, and your apartment burned down, life can be about dealing with the biggest issues as and when they come. This also means that caregivers needed to prioritize the limited time in primary care visits for the issues that were biggest in the moment. And medical systems could make it hard for families to get the care they needed. Caregivers and providers told us about medical systems that were disconnected and hard to navigate. They could find it difficult to get referred to specialists or weren't aware of the need for primary or specialist care as a part of asthma control and preventing exacerbations. So families often ended up using urgent or emergency care. Meanwhile, many children's asthma seemed undertreated. The providers we talked to mainly talked about pharmaceuticals as the most important way of managing asthma. But caregivers used a much broader range of strategies to manage their child's asthma. These included staying vigilant and monitoring children by watching and listening for symptoms, controlling children's environments through things like cleaning, regulating air, or controlling other smoking, controlling children's behavior by encouraging or restricting different activities or places to avoid triggering exacerbations, treating children's symptoms with albuterol or home remedies, and managing children's emotions by calming or comforting. Children also have to and do take on a lot of the work for asthma management. This is because asthma happens in their body and they must recognize their symptoms and decide which of many possible actions to take. They also spend a large proportion of their lives in various places away from their main caregiver. Children's self-management included identifying symptoms of asthma, deciding what to do about their symptoms, and taking medication. Children could also have different perspectives on their asthma from their caregivers. In many cases, children held information that parents did not, particularly about experiences of asthma at school or sports teams. Children developed their own asthma management with siblings, friends, coaches, and medical professionals. Children could give more complete reports of their asthma and treatment history, including names of medications that caregivers could not remember. And children figured out their own strategies within the constraints of their childhoods, like school policy and institutional authority, medical gatekeepers, and mobility. In particular, children stressed the importance of access to inhalers. Children found it stressful when they were not allowed to carry an inhaler, their inhaler was too far away, or the person who kept their inhaler, like the school nurse, wasn't there. Even when children had permission to carry an inhaler, this came with the mental labor of keeping access to the inhaler that could be easily lost, forgotten, misplaced, emptied, or expire. Since inhalers were not always accessible, children had to develop their own strategies for asthma management. Almost all children talked about drinking water as a core part of their asthma management. This makes sense because water is more reliably accessible than inhalers, but it also suggests children are not getting enough support. And providers and parents both tended to overlook children's roles in their asthma management. Providers often appeared to have good relationships with children, but they didn't tend to have a clear idea of what children's roles in asthma management could or should be. This could mean that children weren't always included as full participants in their healthcare, even though they must handle significant parts of their asthma management. Most providers we talked to worried about seeing so many kids sick with asthma in their communities, and about how poor environments and undertreatment were contributing to many emergency visits and hospitalizations. They worried that many caregivers were missing out on the education and support they deserved. We heard about how different kinds of providers are working to bridge the gaps in a broken system, but they all had their own limitations on what they could do. School nurses get to know kids and families well, so they do a lot of work to help identify sick kids, help connect families to primary care, and provide education. Some doctors partner directly with school nurses, but school nurses have no way of prescribing medication, even when they can see kids need them. ER and urgent care providers managed acute crises and tried their best to supply education and refer families back to a primary care provider. But they had no ongoing relationships, no follow-up, and seeing people in the moment of crisis was not the right time for asthma management planning. Some providers worked to create broader solutions for patients, such as wraparound services that included social workers or legal support, but many providers are limited by medical system constraints like insurance, short appointment times, and funding resources. For more information on this study, including our full report, see our website. And thank you to all the providers, caregivers, and children who participated in this study.